Good evening, everyone. Thank you for joining us. This is a patient education webinar of surgery versus no surgery. Our event moderators today are myself. I'm from Washington University in St. Louis. I specialize in pediatric and adult deformity. And my partner moderator is Mike Glotzbecker from Rainbow Babies Children's Hospital in Cleveland. Our guest speakers, we have a great lineup. These are all superstars. We have Amit Jain from Johns Hopkins University. We have Dr. Stuart Weinstein. He's from University of Iowa. Salil Upasani from Rady Children's Hospital in San Diego. And Purnendu Gupta, he's an orthopedic surgeon from Chicago. We also have patient speakers. We have Georgia Karas. She's going to talk about some bracing. And then Bindi Weiland. She had a fusion and she's going to share her knowledge about that. So a few instructions. Please submit all your questions through the Zoom Q&A. It's on the bottom. You can submit your questions, and with time, we can actually ask the speakers to address them, either through the chat at Q&A or actually give you an answer live. So the webinar agenda is quite packed. So we have 6 different presentations, and we'll have a Q&A after each one. So you can see that we have bracing, we have conservative management, we have bracing patient story, we have a surgical long-term follow-up from Dr. Upasani, and we have risk factors to talk about should I do surgery or now or can I wait? And then we have a spine fusion story from a patient's perspective, because obviously surgeons and patients have different perspectives. Just a few things about the Setting Scoliosis Straight Foundation. It's a nonprofit 501c3 established in 2018. It's a great organization. The mission of the foundation is to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide. And the vision is a future where children with scoliosis can have the ability to live healthy, happy, and productive lives. Next slide. So with that, we also have some sponsors that sponsor these events. And we'll have a sponsor from OrthoPediatrics, which is a corporation that makes spinal implants and other implants for pediatrics. And we have the Global Director of Training and Education, Rachel Blossey, who's going to share a message. Rachel, all yours.
Thank you, and thanks for having me and giving me the opportunity to say a few words on behalf of OrthoPediatrics. First, I want to acknowledge the Setting Scoliosis Straight Foundation. We are honored to be a part of the work that they do to advance the care for scoliosis patients. OrthoPediatrics was founded on the cause of impacting the lives of children with orthopedic conditions. And since inception, we have impacted the lives of over 1 million children. And our ultimate goal is to impact 1 million children per year. This is our remarkably talented scoliosis leadership team. Together, we have over 170 years of orthopedic experience. We don't only focus on the end state. At OrthoPediatrics, we focus on the disease state. And we have an offering of bracing, non-fusion options. We have expansive fusion options, as well as an evolving digital platform, which increases safety, accuracy, and data collection, all to improve outcomes. In closing, together we are advancing healthcare for children around the world, and we are proud to make a difference for them and their families.
Thank you so much, Rachel. We all appreciate your help, and I'm sure the patients do as well. Now I'm going to introduce Amit Jain. He's an orthopedic surgeon at Johns Hopkins University, and I'm sure you've heard of it. He's an associate professor of orthopedic surgery, neurosurgery, and business. And he specializes in minimally invasive spine surgery, complex scoliosis care in adults and children. Amit?
Thanks, Dr. Gupta, and thanks to the Setting Scoliosis Straight Foundation for putting together such a fabulous program. And I'm going to talk about a topic that's near and dear to my heart, which is scoliosis bracing. And these are my disclosures, none of which are relevant to this talk. Adolescent idiopathic scoliosis is a lateral curvature of the spine on a radiograph. That's what we think of scoliosis. Frequently, families first see the X-ray, they think, wow, there's a big curve, and they get concerned. It's defined as over a 10-degree curve, but there's quite a range in that. And most of the times it's a right thoracic curve, but can affect both the thoracic and the lumbar spine. So thoracic meaning the mid part of the spine, lumbar meaning the lower back, and then cervical meaning the upper back. But in reality, it's really a three-dimensional deformity. In other words, it is a twisting of the spine, not just on a side-to-side way, but it's actually a rotation and twisting of the spine itself. Now, braces are a really effective way to treat this, and I'm going to talk about why that is. The goal of braces is to prevent curve progression, because ultimately we don't want the curves to get so bad that they need surgery, and our goal should be to try to delay or avoid surgery if possible. And the other goal of braces is to improve spinal alignment and try to improve posture and try to get the kid growth controlled. Indications for bracing is Cobb angles 25 to 40 degrees. So the way we measure scoliosis is we look at X-rays, and on X-rays we look at different angles, and then the most important angle we look at are the angles between the top and the bottom of the curve, and that's known as the Cobb angle. So when it's between 25 to 40 degrees, which is considered a moderate curve, we think that the child is a good candidate for a brace. Furthermore, we look at their skeletal maturity, which is an important factor in trying to figure out if a child is a good candidate for bracing. And we typically think of skeletal maturity in two parts. You think, the child is skeletally immature or skeletally mature. And within skeletal immaturity, we have a way of grading this, and we call this the Risser scale. So we say Risser 0, 1, and 2, and that has to do with how much of the growth plate is visible on the X-ray on the pelvis. We can kind of figure out if the child is a lot of growth remaining or a little bit of growth remaining. So if there's a lot of growth remaining and the numbers are just right, then that's like the perfect candidate for bracing. Fun fact, the word orthopedics itself probably had its origin from ortho, which is straighten, and pedi, which means children. So it's the art of straightening children, likely from bracing. There was a guy named Nicolas Andri, who was one of the original orthopedic surgeons, OGs, from his 1741 book, OrthoPedi, that focused on treatment of straightening children. So cool fact. So braces have a long history. Bracing is super effective in avoiding curve progression. And Dr. Weinstein, who's on the panel here, is one of the godfathers of bracing studies. And they did this big, really incredible study where they essentially randomized kids into braces versus no braces. And what they found is that braces were super effective. In fact, effectiveness was defined as reaching skeletal maturity with less than a 50-degree curve. In other words, reaching a stage where surgery is not necessary. And what they found is that in the bracing group, almost 3/4 of the kids who were braced had success, versus in the observation alone group, only about half the kids had success, with the odds ratio of 2x. That means it was twice as effective as not doing anything. We have done studies looking at cost effectiveness of this, and we have found that it's not only effective, but also cost effective, which is great because that's why insurance companies are willing to pay for it. Now, it turns out that time in brace influences success. There are many factors that you can study, and one of the factors that's really important to consider is how many hours a day you wear the brace. There are other factors associated with success that include slightly older age, because you're probably more closer to your skeletal maturity, so your curve is not going to progress as much. There are some factors associated with failure, so that includes being a boy, having a lower BMI, and bigger curves, especially those that are bigger, stiffer curves, because the braces are just not as effective, unfortunately. But one of the interesting things that came out of Dr. Weinstein's study was that the number of hours the brace is worn is really important. So that's why we always harp on wearing the brace as much as you can, as long as you can. And there was kind of this threshold above 13 hours or so. And above that, ideally, the more you do it, the better. So if you tell a kid, you got to wear 22 hours a day, hopefully that will end at 16. If you tell them you got to wear 16 hours a day, that may be 10. So the number you should shoot for is always the highest number possible. Now, bracing success and curve size have an interesting relationship. And it turns out that if you have a small curve and you wear the brace a lot, you're going to have pretty good success. But if you have a really big curve, let's say a 40-degree curve, and even if you try really hard and wear the brace a lot, you may or may not be successful depending on your skeletal maturity. So large curves generally have a lower probability of success, while smaller curves are quite successful. Now, there's a number of different types of braces: Milwaukee brace, Boston brace, Rigaud-Chenot brace. The Milwaukee brace is kind of the original brace, and it's obviously not frequently used anymore for good reason. It wasn't very comfortable. It was very challenging to kind of put on and put off. But the two that are super popular now are Boston braces and Rigo Cheneau. Boston brace has the straps in the back. So the way I remember that is Boston starts with the word B, straps in the back, that's the Boston brace. It has these push pads that help kind of rotate the spine, and it's made using these pre-made molds frequently. Rigo Cheneau is a European concept that's really clever. So the idea is that the straps are in the front. It's molded for the rotation. So there's no straps or push pads. There's molds that are built into the brace that help kind of rotate the spine. And it's designed using this CAD/CAM technology, which is pretty cool. People always ask, is one brace better than the other? Should I always go and try to find the fanciest, biggest brace? And the answer is no, it doesn't matter. They're pretty much the same. There may be small differences, and orthotist can guide you as to what's better for your child. But the bottom line is the hours worn in the brace is the most important point. So please wear your brace. What about nighttime braces? Well, nighttime braces is another interesting concept. And the idea is that when the child is sleeping, maybe we can provide additional support to the spine. And we can do that in one of two fashions. We can either overbend the spine, and that's called the Charleston brace, which basically has this overbend built into it, and the Providence brace, which essentially is a more comfortable, kind of more midline brace. But the idea is that both of these are hyper braces that essentially force the spine into the opposite direction and are designed specifically for nighttime use. So is nighttime braces effective? And studies again show that the answer is yes. And they did this really nice study, and they found that the nighttime brace works really well to reduce progression and had much higher rate of success, about 74%, versus doing exercises alone or physical activity alone. So in other words, it really does work. What about if I had a kid who had the option of picking between full-time and nighttime? Does that matter? And this study, hot off the press, 2025, basically showed that once they randomized these kids between nighttime and full-time bracing, both were effective. The full-time did have higher impact on self-image and pain, but certainly the jury's out on what is quote unquote better. For my kids, I always recommend full-time bracing as much as possible. And once they're kind of near skeletal maturity, we transition them to nighttime bracing. And that tends to be a really good protocol and really nice way to kind of wean off the brace. I think the most important thing is optimizing brace compliance. And the real world data shows that only about 60% of patients achieve that optimal over 18 hours a day wear. So what can we do to help? Well, you can encourage your child through psychological support. Building reward systems, I think, is really helpful. Tying it to things they like to do, making it fun, making it not painful. Early compliance monitoring can be helpful. Customization and support can be super helpful. And then finally, peer support groups and Studying Scoliosis Straight Foundation and other really amazing societies, such as the Scoliosis Research Society, encourage these peer support groups. And these are great ways to kind of find another kid who is going through the same thing that you're going through, and can be really powerful way to encourage this. So in summary, the goal of bracing is to halt curve progression. It's a super effective and cost-effective way to treat scoliosis. It probably has its origin in the word orthopedics itself. There's a critical threshold of wear, so you should really encourage the child to wear it as much as possible. But if you had to pick a number, I would say over 15 hours a day, ideally, once they're skeletally immature. After school and nighttime is a good option. Full-time is preferred for more skeletally immature kids. And optimizing compliance requires monitoring, celebration, and peer support. And in fact, we have a celebration board at Hopkins where in each of our clinics, if you wear your brace and you do a good job, you can have a Polaroid photo taken of you, and you could be our bracing superstar. I'll end there and transition back for questions. Thank you.
Great, that was fantastic. I want to just remind all the attendees to use the Q&A, and you can follow along with those questions and answers as well to see what other people are asking. In the spirit of time, I think we're going to move to Dr. Weinstein's talk, who's going to talk about what happens in the long term with conservative treatment.
Thank you very much. Good evening, everybody. Well, I'm not going to talk about conservative treatment. I'm going to talk about no treatment. And this is what happens if you don't have treatment for scoliosis, either a brace or surgery. And this is kind of a 30,000-foot view of the subject for the parents and patients alike here. And so taking you back, when I was a medical student and an early resident, the prognosis for having scoliosis was thought to be quite poor. It was thought that you would become paralyzed, you would be disabled. If you were a woman, you would never marry, you could not have children. And this thinking about having scoliosis pervaded the 60s, the 70s, and even the 80s. In 1976, I had the opportunity to look for a large group of patients who were seen at the University of Iowa between 1932 and 1948 when no treatment was available, and get them to come back to Iowa City. And I also made a bargain with them. Can I please see you every 10 years? And so these are some of the papers that are out there. And if you advance to the next slide, for those of you who are interested, this is in the Journal of American Medical Association in 2003. And this is the lifetime natural history of a large group of patients who were never treated. And you can see their average age at the final follow-up was retirement age, average age 66. Next slide, please. Each time they came back for a visit, we gave them validated questionnaires about back pain, pulmonary symptoms, general function, depression, body image. Next. And also I examined personally every single one of these patients, just like your child would be examined at the clinical follow-up for their scoliosis. Next. And you can see that these would probably be worst case scenario patients. The average thoracic curve was 85 degrees up to 156 degrees. The thoracolumbar curve average was 90 degrees. So I would say what I'm presenting to you is probably a worst case scenario. Next slide, please. It's important when you do research that you have a control group, patients who are the same age, same sex, but don't have scoliosis. So at each visit, each 10-year follow-up, I was able to get a control group from the hospital, from retirement homes, et cetera, make sure they didn't have scoliosis, and then give them the same questionnaires as the scoliosis patients. Next slide, please. So when you bring your child to the clinic, the big question is, what's the crystal ball? Will the curve get worse? And if the curve gets worse, will my child have increasing pain? Will they have a normal lifespan? What about the effect of the deformity? What about psychosocial effects? Next, please. So we know that the factors in curve progression, as you already heard a little bit about, are the size of the curve. And we know that the maturity of a patient is very important. And depending on what clinic you go to, many doctors use different maturity factors to assess prognosis and how much growth is left. Next slide. This is a part of a research paper I did in 1982 with Alf Nachemson and John Lonstein. And I think it's a kind of it sets the general pattern here that if you have a youngster whose curve is less than 20 degrees, and you see they're 16 years of age as a surrogate for maturity, there's no chance that curve will ever get worse. If your child reaches maturity with a curve between 20 and 29 degrees, very little chance that it'll get worse. As you get into larger curves, 30 to 39 degrees, even at maturity, there's a slight chance that the curve may progress throughout life. And when you get to a large magnitude curve, even at maturity, the curve has a high likelihood of progression. Next slide, please. This is that group of patients followed over a lifetime, and you can see there's slow, steady progression of their curvatures. Next, please. What I think you can take to the bank is if your child has a curve of 30 degrees or less, by the time they finish and reach maturity, the curve will never get worse in life. Next slide. If, however, the curve is in the thoracic region and over 50 degrees, it has a high likelihood of slowly progressing throughout their lifetime. Next. When you talk about thoracic curves, this is the only curve where you can have objective findings associated with the size of the curve. The larger the thoracic curve, the greater the effect on pulmonary function. There's obviously a lot of things that affect lung function, including the side projection of the curve, how much rotation, et cetera. But what I think is important to realize is some of you look through the literature, there's a difference between children who have early onset scoliosis under age 10, but particularly under age 3, who are their pulmonary function is profoundly affected versus your child with adolescent apathic scoliosis. Very different natural history. Next slide. And this is showing the pulmonary function in thoracic curves from our study on the left and the Harms group on the right. And what it points out is that your curve has to get into the 70 to 80 degree range before pulmonary function is adversely affected. Next slide, please. And why is that important? Well, all of us, as we age, our lung function decreases. So if your scoliosis has already affected your lung function, the aging process will compound that. Next slide, please. What about back pain? Well, I think some of you adults who are listening in may have back pain. I have back pain. It's very common in the adult world. Next slide, please. But when you look at scoliosis patients long-term, they did have more back pain in the control group. Next slide. And patients with scoliosis, their curvatures get arthritic changes over time. So this is a young lady who at age 15 had a 42-degree curve, at age 52 at a 78-degree curve. And there's a lot of arthritic changes here. Next slide. This is her on the left, and she responded to her questionnaire at 30, 40, and 50-year follow-up. I have no back pain. And the patient on the right, whose curve is approximately 20 degrees, had constant daily back pain her whole life. And what I'm getting to here is the size of the curve and how the curve actually looks may not be relevant to the cause of the back pain, and the doctors need to find out what's the pain generator. Next slide, please. And one thing that does happen over time is where the curves transition, like at the lower end of a lumbar curve or the junction between two curves, sometimes the unit, the disc and annulus does fail. And this does happen over time, long-term, and is a pain generator. Next. Next slide, yeah. So I think patients with scoliosis will have more pain on their questionnaire. Next slide, please. But what's really important is that their activities of daily living are exactly the same as control patients. And just because you have a large scoliosis doesn't mean you're going to be disabled or not be able to have a normal life. Next slide. What about self-esteem? Because the curve does cause a deformity, if you will. Next slide. And I think that most of the patients in this series, about a third of them felt they were a little bit self-conscious of their deformity all through their life. Next slide. But none of the patients were depressed or taking medications because it bothered them that much. Next slide. And I think that the marriage rates, this is very important, particularly if your patient is your daughter, the marriage rates are exactly the same as the general population. Next slide. And reproductive experiences are exactly the same as normal children. That's very important. Next. And body satisfaction, I think that there's no question that having a scoliosis can affect your self-image. And there are a lot of factors which are poorly quantitated to say, well, how does this affect each individual child? Next slide. You can see the gentleman on your left wrestled in the 1948 Olympics. It's quite a large curvature. He filled out that his questionnaire, it didn't bother him at all. The lady on the right felt that she would never wear a swimming suit because the curve bothered her so much. So these are just the extremes of how a curve may affect your self-perception. Next slide. And when you come to self-perception, these again, patients were treated between 1932 and 1948. They didn't have what your children do or what you have with the social media. So it's pretty difficult to say that this cohort of patients would react the same if they were living today in this flood of social media, which all of you are subject to. Next slide. I think what you should take away from this is that, yes, scoliosis patients may have more back pain, but they're not disabled by it. Yes, scoliosis can cause some self-perception problems. Large curves over 50 degrees may continue to progress throughout life. Next slide. And finally, that your child can expect to have a normal life regardless. Nowadays, we have treatment, but these patients who lived in an era where there was no bracing, there was no surgery, all had very normal lives. They married, they had children, they were productive in the community. And again, the take home, if you can keep the curve under 30, it'll never get worse. And if the curve gets over 50, then it's an area where the curve may continue to creep up throughout life. Next slide. Thank you very much. Apologize for the technical glitches.
No problem. That was a wonderful lecture. And, you're one of the most experienced pediatric spine surgeons with a great history of research into this natural history. So thank you very much, Stu. Unfortunately, we don't have a lot of time for Q&A. we're going to go right. Please submit your question in the QA box, and then we'll be answering it as we go along. And we don't want to miss on these beautiful lectures. So next up is Georgia Carras. She's actually a scoliosis patient. He's going to talk about her personal journey with scoliosis braces. Georgia?
Hello, everyone. I'm so excited to be here. Let me share my slides really quick. Okay. Hi, everyone. My name is Georgia. I'm 23 years old, and I was diagnosed with scoliosis in 2012, so when I was 10 years old. And my mom had discovered that there was something different about my back when I was reaching down to grab a backpack off the ground. So we decided to go to my pediatrician, where they asked me to touch my toes, and they saw that my back looked a bit uneven. So that's when I was sent to Stanford Children's Hospital, where I got my x-rays done and found out shortly after that I had scoliosis. And this came as a shock to me because I didn't experience any pain and I didn't feel any different before my diagnosis. And then there was a bit of back and forth for the treatment that I should proceed for my case specifically. But ultimately, we decided that because of my young age, the degree of my curve, as well as that I had estimated about 4 years of growing left, that putting me in a Boston brace would be the most effective form of treatment. So, and I was considered to be at a high risk for bracing failure. And because of this risk, that made me more determined to slow the progression of my curve. So I wore my Boston brace every day for 20 hours for 4 years. And I was a very active child. I was involved in swim team. I had dance classes. I also played basketball and was part of a club soccer team since the age of 8 years old. But luckily, I was able to engage in all of these sports that I loved, and I continued to do them. I would just need to take off my Boston brace during my practices and games. And fast forward to 2016, my doctor told me that I no longer needed my back brace because I had stopped growing. And I have a vivid memory of my technician cutting my brace in half, and that felt like such a celebratory moment. And during those 4 years, however, my curve did increase by about 18 degrees. However, my back brace succeeded in keeping it stable enough to where I wouldn't need surgery at this time. So still several years after, now I'm 23, my curve has maintained and stayed very stable. So there's 50-50 chance in the future that I might be needing surgery, but I don't regret wearing my back brace, as I'm really proud of my story and the perseverance that it took. And in 2022, I started Schroth therapy, and I continue to go to my yearly checkups to check on my curve. And my life after bracing has been amazing. I continued to play club soccer until senior year of high school. I also played soccer for my varsity team for my high school, as well as track and field and lacrosse. So stayed very active. And after graduation, I attended TCU, where I met some of my closest friends. I attended a lot of football games, a lot of tailgates, and I even studied abroad in Rome. So my life has just been amazing after. But more specifically, what I'm most proud of, my proudest achievement, I say, post-bracing, would be joining the Setting Scoliosis Straight family as a marketing volunteer and a scoliosis ambassador. Knowing that there's a possibility I'm going to need surgery in the future, I started to do my own research on the advancements of spinal fusion surgery, and that's where I came across the Setting Scoliosis Straight Foundation. I saw the amazing research and advocacy that they've done for patients. So I was inspired to join the team, and that was a really amazing opportunity. I've been able to meet so many amazing patients and hear their stories, which has been so beneficial, because when I was going through bracing, I felt very alone and that others didn't really understand the journey I was going through. So I'm happy I've been able to make these connections, and I encourage others to volunteer for the foundation and be part of the scoliosis community. Thank you so much.
Georgia, thank you so much for being here. I think your words are probably as important as anyone else on this webinar, just because I think it's difficult when you're in sort of that, getting the diagnosis and in that zone, to sort of relate to what other people are going through. And so it's really important that you tell your story. So thank you for being here.
Yes, thank you for having me.
So I think we're going to move on to Dr. Upasani for talk. We're going to shift gears a little bit and talk about surgical long-term follow-ups. We'll move away from the bracing and the observation.
All right, great. Thanks, Mike. And thank you for the opportunity to speak to this group. Are you able to see my slides? All right, great. So I've been tasked to speak about the long-term surgical outcomes. So as we're switching gears, starting to talk about surgery for AIS, I'd love to just touch base real quick on what the goals should be. So our number one goal is to halt curve progression and correct the deformity that's present. While we're doing that, we want to try to maintain a balanced spine in all three planes. So that's while you're looking at the patient from the front, from the side, as well as the axial plane or the twist that Dr. Jain was talking about. We also want to try to preserve as many motion segments as we can. So we want to treat the structural or the larger portion of the spinal curve and leave motion, especially in the lumbar spine. And then ultimately for these long-term outcomes, we want to prevent any of the surgical complications, which we have a lot of research on about junctional kyphosis adding on, which means that the curve that's untreated continues to get bigger, or revision surgery. And I'll touch base on a few of the reasons why some patients might need it. So I have just enough gray hair to start to have some 10-year follow-up for patients. And so this patient is 10 years out from surgery. You can see a very well-balanced spine with minimal residual deformity, a well-healed incision, and she's in her 20s, but still a long life ahead. So these long-term follow-up questions are some of the, the most important questions that patients ask before their surgery. And while we have some data, I'm going to explain to you, why we don't have great data like Dr. Weinstein just presented with 40, 50-year follow-up with the natural history, as in untreated scoliosis. So the evolution of surgery for scoliosis is seen here. So the first spinal surgery was performed in 1911 for a spinal deformity. And then the surgeries have evolved quite a bit. This Harrington, which I'll show you a photo of, an X-ray, which was developed in the 40s. And then we started to treat these deformities from the front. So an anterior approach to the spine by Dr. Zelke in 1969. And then Cottrell and Dubussé really introduced this concept of segmental instrumentation, which is what we do now in terms of placing screws at multiple levels to try to control the spinal curve by addressing it at all of these levels. So here are some X-rays over time. So in the 60s with the Harrington rod, we used to put one straight rod and just distract the spine. Obviously, a very one-planar correction on that AP or coronal plane, we could get the spine straighter, but it caused a lot of issues in the sagittal plane or from the side view. And then the Cottrell-Dubussé instrumentation from the 80s to what we're doing nowadays with segmental pedicle screws and pretty powerful three-dimensional deformity correction. So there's this one really good study that did a systematic review in terms of the long-term outcomes for scoliosis. It was published in 2024. It looked at our literature for all the studies that had more than 15 years of follow-up for these patients. They were able to look at 1,115 patients. 324 of them had an anterior approach. Most of them had a posterior approach. And on average, they were followed for about 22 years. So what did all these 19 studies in our literature show us in terms of the long-term outcomes of surgery for scoliosis? So just some take-home points in terms of radiographic correction or how well we're able to straighten the deformity. You can expect about a 60 to 80% coronal plane deformity correction, and it's definitely maintained for that long-term follow-up. There was a question in the chat earlier about the uninstrumented spine. So you can expect about a 50 to 60% of correction if you're leaving the lumbar spine uninstrumented. And that also is maintained after a long-term follow-up. So you wouldn't expect the lumbar spine to continue to progress if the thoracic spine is addressed appropriately. In terms of pulmonary function, so PFTs were decreased after an anterior approach to the thoracic spine. But most of those patients had no complaints or limitations in their activities, whereas the posterior approach, which seems to be the gold standard nowadays for the vast majority of patients, pulmonary function was basically normal compared to a control population. In terms of health-related quality of life, so these are the measures that the patients are reporting on how they're doing. AIS surgery was found to have no adverse effects in terms of pain or mental health 20 to 40 years after surgery. And in general, the quality of life is as good after surgery as the general population, again, at this 20-year follow-up. In terms of adjacent segment degeneration, now this is the big issue that we're all somewhat concerned about. What's going to happen to the unfused spine 30, 40, 50 years down the road? And again, with average of 20-year follow-up, X-rays show that there is some changes in the spine below a fusion. For example, some arthritis that's starting to develop in the facet joints, in the discs, as well as spondylolysis, which means like some changes at the lower lumbar spine. And again, this study by Weinstein showed minimal degenerative changes. So there's definitely changes that are going to happen in the unfused spine. However, at this 20-year follow-up, the data that we have, it doesn't seem to be impacting patients' lives or causing chronic pain or limitations. And so this data looking at the low back pain goes to that. So there's minimal incidence of back pain. It doesn't seem to be associated with how far down you go with your fusion. But there is some effect on how well you can get the sagittal plane balanced. So I talked about the different approaches that you can use to treat the fusion or the deformity, and the Harrington rods, which led to a very flat back, are definitely associated with more issues in terms of back pain than some of the newer segmental deformity correction strategies that we're using nowadays. In terms of reproductive health, 2 studies showed that there were higher rates of cesarean sections after AIS surgery compared to the general population. And we can answer some questions or talk about that a little bit more. You need to go with an anesthesiologist who's comfortable with epidurals in patients after fusion, and it can change the approach to some of these deliveries. In terms of the complications or revision rates, there's about a 5 to 10% long-term complication rate for adolescent idiopathic scoliosis. A lot of these tend to be late wound infections, which can either come from acne type of bacteria that can get into the wounds, pseudarthrosis, which means that the fusion doesn't take for some reason, which can result in implant failure, changes at the top or bottom ends of the fusion, or this concept of adjacent segment disease, which means that early arthritis that's starting to form at the bottom end of a fusion. But regardless, so I feel like the data is very incomplete. We only have these 19 studies with retrospective data, and we really need more prospective data that's being collected by the HARMS study group. So the HARMS group just celebrated its 30-year anniversary, and there's a big push to get these prospective patients back so we can see how we're actually doing with modern instrumentation in terms of the outcomes that are coming up. So thank you so much to Setting Scoliosis Straight, and I'm happy to take questions.
Thank you so much, Salil. That was a great summary of many, many years of surgical treatment evolution. So unfortunately, we don't have a lot of time for question and answer. We are running short, but please, I want to remind people to put the question in the Q&A, and I want to thank the speakers that are answering these questions quite well. I've been monitoring that. So next, I think I'm going to introduce Dr. Purnendu Gupta. He's at the Shriners Hospital in Chicago. He's the chief there, and he's very well experienced in pediatric spine deformity. So he's going to talk about risk factors. Should I do surgery now or can I wait? And I want to answer one question ahead of time. You guys all might be wondering who he is. He's my brother. So Purnendu, please.
Thank you so much for the introduction, Manish. Such a pleasure to present this evening. So my topic is do now or should I wait for surgery? So let me explain and try to go through some of the factors that can help us in decision making. So first and foremost, what are the things that we're looking at to make a decision? So age is a critical factor, as some of the presenters have always mentioned. The younger the child with scoliosis, the more likely to progress. Curve magnitude at presentation, that's really important as well. The larger the curve at presentation, the more likely to progress. Curve location is a little more finer finding. and we can talk about that. But I think the other markers of maturity, meaning how fast are they growing, which in young ladies we know partly from menarchal status, and skeletal markers is something we really hone in on as physicians to make those decisions. You can see some of the pictures that I have there. On the top left is the iliac or visceral staging. And someone already mentioned that we're looking at the cartilaginous cap that goes along the top of the iliac crest, and that helps us to understand how skeletally mature the child may be. The two pictures on your left at the bottom of the screen talk about the triradiate cartilage. That's a little clear space you can see in the middle picture in the acetabulum or in the hip joint, but you can see in the lowest picture on your left that's closed. And on the right is the standard staging. And there have been questions in the chat already about that. And that looks at the growth plates in the fingers to understand how skeletally mature the child is. So let's take a look at some of these risk factors. This is an old slide, but it's one of my favorites. And it talks, the dotted line shows the growth velocity of the child. And you can see there's a peak and then the growth tapers off. That peak occurs during the first sign of puberty. And typically 2 years after menarche, you see the onset of the growth spurt. And then point R, which is where the curve goes flat, the black line is the curve magnitude. That is when they've reached that skeletal maturity or cessation of growth. Now let's take a look at the Risser stage and curve magnitude. So this 3D bar graph on your left shows the percent of progression to surgery. On the front line, you can see the triradiate cartilage is open. You can see those bars are quite tall, shows there's a high risk of curve progression. Then in the second line, you see that the triradiate cartilage is now closed, progression is less. So now the child is older when you get to Risser 1, which is the first stage. And you can see the higher the curve at presentation, which is all the way on the right, the more likelihood of progression. But once you get to Risser 2, most of their growth is done. And at that point, the likelihood of progression is less. The Sanders staging, what we're looking at, I just want you to pay attention to the bottom left picture. And that shows the fingers. And the tiny little growth plates in the fingers is what we're looking at. And as those growth plates close, you progress along the Sanders staging, which is shown in the top part of the screen. And that is also associated with skeletal maturity and puberty and maximum growth velocity. This is a table that shows as you have a higher Sanders maturity, if you look at the columns, goes from Sanders 1 and 2 to Sanders 7 and 8. And then on the left side, you see the curve magnitude. The greater the curve magnitude, the lower the Sanders score. On the top, as you can see on the left-hand side, the reddish shows risk of curve progression. So this is just a general idea so that everyone can understand some of the factors we're looking at as surgeons to make decisions. So can we wait or should we do surgery? This is a 14-year-old that presented to me and was 3 years post-menarchal and Risser 5. So all the factors that we've discussed should indicate that she shouldn't need surgery, or at least she shouldn't progress. And indeed, that's the case. And you can see her follow-up. And then we know that this curve will be stable for a long time, but possibly may progress in adulthood. But for now, we can wait. There's no harm in waiting. How about in this situation? Can we wait? Well, this is a severe curve. And many times patients will present to me and they have a double major curve pattern and they look square because their shoulders are square and they look okay frontally, but they have severe curves and the parents are aghast when they come to see us. And so we reassure them, but they shouldn't wait. They should have surgery. This child needs surgery. We know it's going to affect their lung function and ultimately their cardiac function. So they need surgery. And it just shows an example of some of the surgical instrumentation that we use that was just discussed. So I have a couple of illustrative twin examples, which are kind of neat and I find really helpful in understanding. Twin A at the left presented with a larger curve, as you can imagine, So she was 6 months post-menarchal and was RISR 1, so she still has risk of progression. Twin B, on the other hand, came to see us, and she's premenarchal, but RISR 5, interestingly enough. And so as you can see, she's less likely to progress. And as we look through the slides, Twin A, we cannot wait. As you can see, she's progressing, and so she was offered surgery and underwent surgery. On the other hand, Twin B, we can wait. You can see her follow-up for almost 3 years, and she started with a 24-degree curve, progressed a little bit to 32. You can see her Sanders staging, and ultimately we got her out of the brace. And whenever you get the child out of the brace, there's always a little bit of sag that occurs, and you can see that in this post film at 17+7. So one of the things that we want to remind everybody, I think bracing is extremely successful, but we have to remember that when you take the child out of the brace, there's going to be a little bit of progression as the curve sags. So there's some immediate, some short-term, and a little bit of long-term progression, but it's really sag that's occurring. And I recommend a weaning process when I take patients out of the brace. That's my usual MO. Here's another twin example. So twin A, as you can see on the left, presented with a larger curve. She's premenarchal, her triradiates are open. We all know that she is at high risk for progression. Twin B, on the other hand, is premenarchal with triradiates open, but has a smaller curve at presentation. As we follow twin A, initially we can watch, but you can see that the curve unfortunately is increasing, and she's been in a brace. She's still premenarchal, then she's RISR 3. And then as we follow along, we find that the curve gets into the 50s, which is the tide mark that Dr. Weinstein had explained to us. And you can see that she's continuing to progress. So she underwent surgery, and we did a selective fusion on her. We did not want to instrument her lumbar spine. But that shows what happens with twin A. Twin B, on the other hand, we can wait. She started at 18, held on pretty well with bracing, and then has ended up around the 34-degree mark. She's weaning out of the brace, and hopefully the curve will sag a little bit, but hopefully will avoid surgery. So again, to review, when we're making decisions of whether we can wait or we shouldn't wait, we have to look at the age of the child, the curve magnitude at presentation, their maturity, and we look at the constellation of these skeletal markers to make a decision. None of them are perfect, but the combination of them helps us to make a good decision about the future. Thank you so much. I appreciate the opportunity to present.
Thank you for a fantastic presentation. So now we're going to move on to the second highlight of the program. Apologize to the other surgeons, but we have another patient speaker here. Bindi is going to talk to us a little bit about the other side of the equation with her experience with surgery.
Hello, everyone. Thank you so much for having me today. I'm so excited to share my story. So my journey with scoliosis started when I was about 5 years old. I was diagnosed with a condition called pectus excavatum, where the sternum bone caves in. So they kind of kept an eye on that until I was about 12 years old, and then they decided the best option for that was to go forward with surgery. So I had the NUS procedure to correct that condition, and that was in 2021. And then they noticed after that my scoliosis started to increase. It started to get pretty bad, but I decided that for me, I would like to wait a year and just see, they kept an eye on it, just make sure everything was okay. And then once my curve had reached 60 degrees, they decided that the best option for me was to go forward with spinal fusion surgery. That was a really tough decision because just knowing everything that goes into that, and I'm a very dedicated dancer. I'm continuing my dance career. I want to go on to dance in the future. So that was really scary. I didn't know if I was going to be able to continue doing that. So I decided to go on with the surgery. So I think that's my next slide. Thank you. So I went through with that. It was a 6-month recovery period. until I could get back to starting back with my activities again. So that was hard, definitely, to have to sit out for so long of my classes and just the anticipation of seeing my recovery and everything. There were a lot of mental setbacks also that went with that. It was hard when I started going back, knowing that I would never be at the level of flexibility in my back that I had before. But I definitely did have a lot less flexibility, but I have learned over time just how to like work around that, and I can do things my own way, even if it's not perfect or doesn't look like the pictures, but I still can do everything. So that's super good and nice to know. So I think next slide, please. Thank you. So I was chosen this year for the charity outreach program with Ohio Dance Masters. So Ohio Dance Masters is a dance convention and competition out of Ohio. I applied to their program and they accepted me. They just saw my story and thought that I would be a good representative for this year. So I'm so thankful for that opportunity. So I got to travel around to all the Ohio Dance Master conventions. I got to speak and perform at every event, which was extremely fun. I loved that. And I also went along with that. I got to pick a charity to raise money for all the whole time of last year's season. And I picked Setting Scoliosis Straight. I was looking for a charity, and my doctor, actually, Dr. Flynn, he recommended Setting Scoliosis Straight. He said it was a great charity. I read all about it, and I just loved everything they were doing. And I just thought that's got to be the one. So we raised a total of $5,348.25 for Setting Scoliosis Straight this year, which was such a great opportunity. I'm just so happy that I got to do that. And now I'm fully recovered and I'm at the point where I'm fully back to dance. I can do everything. I can probably do more now than I could before, just because I just work so hard and just want to get everything back all the time. But since my spinal fusion, yeah, my life has really gotten a lot better. I think I've had a lot less pain. My breathing has gotten so much better. And I still plan on becoming a professional dancer. So that's one thing that's really important to me, that I can still pursue my dreams even though I had spinal fusion. But yes, with determination, you can overcome anything. So yeah, thank you.
So thank you so much for that great presentation, Bindi. I think we caught up in time, maybe a minute to answer any questions you may have. I really appreciate all the lectures and all the sharing from Bindi and Georgia, and all the questions that were sent. There were 36 questions sent, and all of them were answered by our panelists and lecturers. So if you have any questions, please submit now. Otherwise, I'm going to have my co-moderator, Mike Glotzbecker from Cleveland, close it out. Thank you so much.
Great, thank you. And this webinar is just one of many examples of how Setting Scoliosis Straight is really dedicated to education, and specifically educations for parents and families. So this is a QR code for our handbook. It also can be downloaded for free in a digital version on our website. And it gives lots of great information of commonly answered questions that you may have, and can really help you with your journey. So next slide. Similarly, if you want to subscribe to our YouTube channel, we have lots of videos. It includes videos that are educational, research videos, patient stories, interviews, lots of information that can really help you along your journey. There's also videos with frequently asked questions, and webinars like this are also posted there so you can go back and review them, because often the pace of these is pretty quick, so it's nice to be able to go back. Next slide. We're able to provide all of these webinars for free, which is, I think, a great opportunity for people that want to learn more about scoliosis. We also couldn't do this without you. So we rely on donors from physicians, but also our patients and people who participate in these webinars. So if you found this valuable and want to help other families and children in the future, there's a QR code that you can also text scoliosis to 41444. To help support similar type educational activities in the future. Next slide. So just as we had this webinar, there are 3 more coming up in 2025, including a patients to patients on June 26th, a webinar on Sherman's kyphosis, which is August 28th, and then a vertebral body tethering versus spinal fusion on October 23rd. Next slide. And I also encourage you to visit our website. This is sort of the home for all of these things that we just talked about, and there's also a lot of additional information. There's great patient stories there to help you relate to the things that you may be going through. We've also realized that the parents go through this journey as well, and so there's going to be a new edition of parent stories where they can interact and share their stories through the journey. And coming soon, we're going to have a Scoliosis Talk, which will be having podcasts with scoliosis-specific information directed at families and children. Next slide. Thank you again for attending. One of the most important things that you can do for us is fill out the survey at the end of this presentation. We really do use your feedback to make these better and tailored for you. And so we appreciate you taking the time to fill that out. And if you have further questions, feel free to reach out. The website is posted there, also our email address, and happy to answer questions that you feel were unanswered or ways that we can help you in the future.